Good afternoon and welcome, everyone. I'm Christy Newton, co-facilitator of the TBC at UBC Network. I'm also the Associate Vice President Health Pro Tem and an Associate Professor in the Department of Family Practice in the Faculty of Medicine at UBC. And today I'm joined by Lee Yates, TBC at UBC Network co-facilitator and Clinical Associate Professor in UBC's Midwifery Program, also in the Department of Family Practice within the Faculty of Medicine at UBC. Thank you all for joining our network event today. Before we start, I'd like to acknowledge that UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people, and that the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Sayalks Okanagan Nation. I would also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. And I acknowledge the traditional owners and caretakers of those lands. I am attending from Port Moody, the traditional unceded shared territories of the Coast Salish people. Please feel free to share the lands from which you are attending in the chat. Now, a little bit about the network before we go into our event. The TBC at UBC Network is supported by UBC Health, which works under the Office of the Vice President Health to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaborations across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy, to ultimately address inequities and improve the systems that foster and support health. The TBC at UBC Network convenes health professionals and leaders, community members, academics, and policymakers to bring forward questions and ideas important for team-based care in British Columbia. The network supports and complements province-wide efforts to enhance team-based care in British Columbia by focusing on education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and connect their efforts. Each network event applies a different lens to the themes of research, pedagogy, and innovation. And now I will hand it over to my co-facilitator, Lee, to talk more about today's event.
Thanks so much, Christy. Before I introduce our panelists and talk a little bit about what will be the conversation today, we'd like to begin with a poll. So I hope you'll share. The poll should have popped up on your screen. I hope you'll share what perspective you are bringing to the conversation today. Looks like we have health professionals and clinicians are 1/3 of the folks in the room today. We have some health authority, government, and health administration folks, and some UBC faculty, staff, and students, as well as researchers in the room with us today. In today's session, we want to look back at our previous network events and the many questions that have emerged as key issues in how we understand, teach, and provide team-based care in BC. Together, we've discussed virtual communication technologies in team-based care, innovative disciplines in team-based primary care, how we define team-based care, and treating behavioral health issues in team-based primary care. We'll start our conversation today with a panel discussion responding to some of the most pressing and impactful questions that have emerged from our conversations over the past year. Our panelists joining us today are Dr. Kim McGrail, former Director of Research at UBC Health, Scientific Director at Population Data BC, Scientific Director at the SPOR Canadian Data Platform, and Professor in the School of Population and Public Health and Center for Health Services and Policy Research in the Faculty of Medicine at UBC. Dr. Ray Markham is Special Advisor to UBC's Vice President Health on Health Systems and Executive Director at the Rural Coordination Centre of BC. Donna Drynan is Director of Education at UBC Health and Associate Head of Fieldwork and Clinical Faculty Affairs in the Department of Occupational Science and Occupational Therapy in the Faculty of Medicine at UBC. After the panel discussion today, we'll move into breakout rooms where there will be time for open dialogue with our panelists and one another. We ask that you bring your questions to these discussions. After the session, we'll have an extra 30 minutes scheduled between 1 and 1:30 for informal conversation in the large room for those who are able and available to stay. So why don't we get started? I see our panelists have joined us on the screen. And we'll launch in with our first question for the panel. The question is, interdisciplinary and interprofessional research takes longer, but is important to develop. What can promote more interdisciplinary approaches to researching healthcare issues and teams?
So I think that's probably an obvious one for me to weigh in on first. So thank you, Lee, for that introduction and for everybody for the opportunity to be here. So I'm going to answer, probably not fully answer, but provide some perspective on this in a few different ways. And first is the sort of construction of the question. It's saying interdisciplinary and interprofessional research takes longer, and that's a probably an important but also interesting framing, because I actually think that while it may take longer because you have to convene the right people and have some additional conversations, and sometimes that interdisciplinary space, it does take longer to make sure that we're all talking the same language and meaning the same things with what we're saying, but it's far more powerful research. So yes, longer, but will produce things of higher quality and higher relevance to everybody who's involved. So I think there's no, I think at some level we should not apologize for that, because it is going to produce a better product. So then I think if we're engaging in this space, we need to think about at least a couple things. So one is, given the interdisciplinary nature of things, how would we judge success if we're talking about team-based care and doing research and healthcare delivery and the functioning of teams in that space? What are the things that we care about? How would we measure whether we've actually achieved what we want? And that kind of collective conversation would lead us to the kinds of things that we might want to make sure that we're measuring, keeping track of, that sort of thing. Because that is like in the sort of program development sort of space, we think about working backwards from the goals at the end. So that a good research project is going to be designed around understanding the processes that we use to get to those agreed on measures of success. And this, of course, could be qualitative research, it could be quantitative, it could be mixed methods. Ideally, probably would be mixed methods in some ways. The other thing that I think we really want to think carefully about is, what are the things we already know from good research evidence that we're trying to implement in that team-based kind of setting? And what are the things that we actually need to develop more evidence to understand whether what we're doing is the right way, or going to be a productive or the most efficient way, or the most effective for the variety of patient groups and patient needs that we're talking about, and person-centered care and all of those kinds of other things. Because if we're thinking in the place where we think we understand there's good evidence for something, we probably take more of an implementation science approach to the research that we're doing. And if we're thinking about things that actually need evidence, but we think it's a good thing to try, then we take more of an evidence development sort of approach. And those would have different kinds of expectations around who needs to be around the table, and the methodology that you'd use, and that sort of thing. So I think the way to promote the interdisciplinary approaches really comes from how we construct the questions, who we invite to the table, and when those invitations are made. So true interdisciplinary research will include all of the stakeholders and all of those interests from the very, very beginning, where we're actually trying to structure the interests, the questions, the goals, and everything along those lines. So I think I probably just said quite a lot there, so I will stop there for now. Thanks.
Yeah, go ahead, Ray. Of course.
Yeah, so hi everyone, Ray Markham. I'm a rural GP in Belmont, which is on Clatteton and Simp territory. I'm not a researcher, and so I'm kind of really, this is kind of wide-eyed and naive comment, but and I don't know, Kim, if you wanted to not specifically for you to comment on, but maybe you might choose to. Kind of seems to me, kind of looking from the outside, that the research environment currently is not really built as a team-based sport. It's kind of more built as a competitive sport where number one on the article, competing for grants, even competing for publications and that. So I guess, so that's my outside view. So I don't know if that's actually kind of your sense or other people's sense of the environment. And I'd be curious to know if there are ways that we could value actually researching and publishing as a group, if there would be things that we could do in the academic environment. Even if you're on a tenure track, if you number ones on an article gets you up there, and if you're part of a team, that's not as good. So, well, that's my sense anyway. So I don't know if that's a fair sense, and I don't know if you had any thoughts, Kim, or anybody else on that.
I may be a poor person to respond to this because I was an accidental academic, and I chosen not to pay attention to some of those like sort of traditional markers of success. However, I am now a tenured professor at UBC, and I think that means that it's my responsibility to make sure that that we do two things at the same time. One is challenge the current systems that don't place the right value on group dynamics and community-based embedded research and those sorts of things, and still do pride the counting of publications over other things. So we push on those kind of evaluative criteria. But the other is to make sure that as somebody who doesn't have to worry so much about CV and all of those sort of traditional markers, to make space for the people who are still having to live by those things and provide support for people to be successful in those environments. And I think there's an extra special thing in here too, that if we're truly wanting to do interdisciplinary research, it will involve members of the public and patients who need different kinds of supports and rewards and recognition, and also clinician scientists who I know struggle mightily to balance their interest in research and the provision of clinical care. So there's a lot of work to do to make these spaces hospitable, as you say, Ray, but I don't think it's beyond our capability of doing that.
I would challenge you that you're not a researcher on your first statement, Ray, because I think we're all contributing to research as we move the system forwards. And your comment extends well beyond just the realm of research, as we've identified, right? Academic policy and promotion, tenure. What do we value? Are we, there was this phrase that was treasure what we measure or measure what we treasure. And I think we're needing to switch into perhaps promotion and tenure based on measuring things that we truly treasure now. So that collaboration, that inclusion, that that kind of thing. So thank you. Great conversation. Any other comments on that first question?
I might just add from a different perspective. I think we've been trying to answer the question, does what we do with our pre-licensure students to prepare them for team-based care and working in teams, does it make a difference? Are we actually producing team-based practitioners? And we are having a really hard time measuring that, right? Like those longitudinal studies, following, ensuring we get all the stakeholders, which are the students, the faculty, the clinicians, the patients, clients, community, et cetera. So I think we do little our research studies along the way, and lots of program eval, and pat ourselves on the back about, yeah, our programs are good, you know, they're meeting some learning objectives, but are we truly making a difference? I think is a really, really big question that we need to still chip away at.
Continue learning, and moving forwards one step at a time. Okay, thank you. We're going to move on to another question for the panel, and it's how do we build and support trust in interprofessional care teams?
So I think I said I might start on this one, and this is such a this just prompts more questions than it provides sort of answers for. And the concept of trust, I mean, it's been studied everywhere in organizational science and behavior, and but you know, more recently put into the healthcare context with practitioners, and just with, you know, coming out of COVID, I think the concept of trust is even more so necessary and requisite, but it's even that much more challenging now. How do you truly develop, how do you define trust, for one thing? People can't land on a definition of that. How is it enacted? And particularly, how is it enacted now when many folks are not necessarily going to be co-located in some of our teams? You know, can you build trust through an academic or an electronic health record? You know, what is it within, and why is trust so necessary in healthcare teams? And I think also trust really requires folks to expose some vulnerabilities, right? That I don't know this. It's not my place to know this. I'm going in, people know me, know I talk about this foregrounding and backgrounding in healthcare service provision. I'm in the background now, but I trust you, all you upfront people right now who are necessary and required at this stage of this person's journey, healthcare journey. But then you need to trust me when it's my turn to be in the foreground. So I think there's a huge piece around vulnerability. It comes also down to folks' resiliency. I think there needs to be some sharing of scope and you know, our silos, and using Ray's terminology of making our silos more porous, so that we can not encroach on each other's, but to truly support each other. But in this day and age, we need to help and support and ensure that we all feel safe within what we're doing and respected in what we're doing. Just raises more questions for me than having answers for y'all.
Hi, I'm Charlene. I'm a primary care network case manager. I'm part of the new program that started, a part of the primary care network, the longitudinal case management program that started a year ago. So for me, building trust with other clinicians, other disciplinary team members has been a challenge. And I would say the biggest thing for me is communication and transparency. So the fact that I am, I'm a registered nurse, so I do a lot of my charting and power chart. And so a lot of other clinicians can see that charting. They know I'm involved. I'm also involved on the Paris platform, where they can see that I'm involved with the client. And I think that when they can see that I'm involved with a client, they then know that I'm there. They know I'm working on a client. They can see my charting. They can reach out to me. They have ways of getting a hold of me if they need to. Where there are other programs that their charting is all in-house. You don't know who's involved. You don't know what their assessments are. And so it's harder to know what's going on with that client because you don't know what their assessments are. You can't see anything. You don't know anything unless, you know, they reach out to you. So I would say for me, building trust would be having a really good platform for all parties.
Thanks. I also heard transparency, I think was another thing. And I've read a couple of things about consistency as well builds trust. So pattern, your consistent behavior and your consistent interactions. Any other comments from the panel? And Ray?
Yeah, thanks, Christy. Donna, I agree with you. This raises a whole bunch of questions. This one in particular, and things like why do you want to build trust? I think from the previous comment, who's the team? Do you know who the team is, and how you're defining the team? Are you defining the team around the patient, as she kind of correctly, kind of notified, or are you defining it around, your little kind of in-person team and all of that kind of stuff? I think there are two pieces here for me. One is how we as individuals approach trust. So individuals in the team approach trust. And there are two ways, two kind of, on a very kind of basic level, two ways. You can say trust is earned, which takes a long, long time, or trust can be given. And that implies that vulnerability, I think, that you were talking about, Donna, is, it's much quicker if you give trust, but much more likely to kind of be hurt in that whole process. And so kind of that's a very interesting question. That's for each one of us, I think, as individuals. And then, organizationally, I definitely agree with the earlier comments around you need to know who the team is, and the team, I think, should be built around the patient, defined by the patient. And then secondly, we need to think about as a system how we value those things that actually build trust. So those are things like connection as human beings, things like valuing space, spending time together, being curious and valuing curiosity, and all of those kind of things, which are, again, bigger questions. And often those are things we don't, when we're under pressure, we don't actually invest in those things. We invest in the surface rather than going deep.
And maybe I'll just add a couple of things to what's been said already. I work in the space in the area of public deliberation, and the way I tend to think about this is that trust is something that's earned, and it's earned through trustworthy behavior. So we can't just ask for trust. We actually have to all kind of act in that in a way that would deserve that trust from other people, which I think is very consistent with what both Ray and Donna have said. And then I think, just picking up on some other comments that have already been made, it's that I believe that trust in part comes from having that shared platform, and the shared platform could be an EHR, which was a sort of would be a good but not sufficient piece of that. But then there's also the other kinds of shared platform that Ray was hinting at, which is the values and the principles that you have, the shared ways of working, the understanding that the team has that doesn't at each clinical interaction level, it revolves around a person, the patient who's receiving services, but there's a way of interacting and an understanding that you have about shared commitments that transcend that and cut across every patient that might be shared across the team. So it takes some effort to build a team that has trust in it, but the benefits are very clear, both in the satisfaction with work and with the outcomes for the people who are receiving care, who are also, frankly, part of the trust circle as well.
Thanks for those excellent remarks. I think I would add to it that trust is relational for me. When I think about teams, it's very much relational. And in medicine, it's relational in what is more often a landscape of technical skills. So we can sometimes, I think, run into the challenge of the things I need to do, and this goes to what you were saying, Ray, the things I need to do supersede the time to be in relationship. I also think that the tools such as effective EMR are enablers of communication, and within a team can help teams practice and build on cohesion, unity, and consistency, which then within the team build that internal trust and confidence, I think. I'm going to move us on to our, keeping an eye on the clock, move us on to our next question, which is, how might we integrate patient partners into education in team-based care?
So I'll maybe jump in on this one, and maybe segue from your comments, Lee, and from the comments in the chat. You know, one of the things actually is around where does the patient's data sit, and it should really sit with the patient. And so fundamentally, that's where everything needs to kind of be centered on and communicate, and that then brings the patient into the relationship, brings kind of patient into kind of the dynamic of kind of what the environment is and what the learning needs are, and kind of where the learning gaps and opportunities are. You know, for me, you can kind of almost take this from a micro, meso, macro, or as Grand Chief Doug Kelly would say, the river's edge, kind of the forest and the mountaintops. And I think they're all important and kind of all a little different. You know, at the clinical interface, I learn from my patients all the time, and I know we all say that, but part of that is actually dropping the cloak of perfection and recognizing that you don't know everything and that you don't get it right all the time, and that's actually really difficult, and that requires a lot of trust to do that. And so, coming back to the previous conversation, and I think for myself as a clinical preceptor for a variety of interprofessional students, actually creating a space and demonstrating kind of the learning from patients at the clinical interface is one example, and is super important. I think we need to value that. At a meso level, kind of community or regionally, you know, as we build and look at education in community or education in regions, I do think our communities and patients really bring a lot to the table, be that from identifying kind of what the needs might be, kind of the health needs, the service needs, or the gaps might be that we don't even see, to actually solutions. So this question is particularly about education. And I would say from my perspective in rural, you know, things like housing in rural communities may not necessarily be kind of the clinician's role, but actually maybe communities and patients kind of maybe kind of involved in shaping that. And then the last piece at a macro level, just the one illustration that I would give would be, we've been doing a lot of work around this. The Partnership Pentagram Plus is a model of socially accountable health system change, and that integrates obviously patient and community as a meaningful voice in shaping kind of almost as a learning community, shaping kind of what educational needs might be, how curriculum might be developed, some of those bigger questions. And it is accepted certainly in the medical schools as kind of the model of social accountability for that. But one of the things that's been really interesting to me is it's very easy to slip into lip service, certainly in the meso and the macro levels, where you'll have a patient voice, a patient representative there. At, you know, a table that's in dialogue can't be a table of 300 people. It's usually kind of a smaller number of people. So you got one or two kind of each perspective maybe there. But like, so as providers or as health administrators or policymakers particularly, we have a huge infrastructure behind us where we actually sort through, sift, think through, kind of bringing kind of the pointy end to whatever that conversation may be. And a lot of that doesn't really exist for our patients and communities. So, you know, that idea of what certainly in the real world will frame a collective perspective is super important. So a space where patients and community can actually come together and sift through and figure out kind of things kind of within their perspective group, and then actually kind of come more meaningfully into those conversations where it's not just a person with a perspective with nothing behind them, kind of at a table where you have people with these huge behemoths behind them. And so that just would bring my last comment in, which is I do think we need to reframe and rethink power and value power. And it's not saying we need to kind of dumb down kind of where they are true power. So like in the education realm, it's kind of, there's obviously going to be finances as a part of power. You know, the kind of academic knowledge is a part of power and have true powers. But what we don't do is we don't value the other sorts of power that come up. And I think the power from community and from patients, what they really bring to the table, and how they can really point and shape together some of these other pieces of how to things that are really meaningful. To Donna's kind of point earlier around, are we doing what we're doing? Is it actually really doing what we think it's doing? If we wanted to really do what we think it's doing, a part of it is actually kind of recognizing and valuing the power that community does bring to shaping those conversations, and doing that beforehand, not kind of when things go awry.
Thanks, Ray. It's interesting. You just described a process that we went through at UBC Health with respect to our patient advisory committee, having individual patients sit on different committees, but then not having that infrastructure behind them. And so we've actually now built it into our terms of reference that these patients, individuals on these different committees are there as ears, and that bringing that information back and then chunking it through on the entire committee with that sort of broader community support is actually what we were hoping to achieve, and not burdening those individuals with that sort of thou shalt represent the entire population of patients and have all that information and perspective. So thanks. So breakout rooms. There are going to be 3 breakout rooms, and you will be prompted to choose one, and it will be focused on either practice innovation, education, or research. And our panelists will be joining the breakout rooms to contribute to the discussion and answer any additional questions that you've come up with. For breakout room 1, it is practice innovation, and Ray and I will be there. And our question will be, what questions do you have about building the culture and the trust needed in interprofessional care teams? Breakout room 2 is education, and it will have Victoria and Donna. And the question will be, what questions do you have about integrating patient partners into education and team-based care? And breakout room 3 will be Lee and Kim. And the question will be, what questions do you have about how to promote interdisciplinary research in team-based care?
All right, I think everyone's back in the main room now, and I hope that the conversations in the breakout rooms were robust and engaging. I'd like to just take a moment before we transition to our informal session to thank our panelists for sharing their perspectives today, and to everyone in the room with us today for contributing to the conversation and bringing forward questions and ideas that are important for team-based care in BC. As mentioned, we've scheduled an extra 30 minutes to our session to continue the conversation for those who are available to stay longer. And some of our panelists are also able to continue and join us. Before we wrap up the main portion of our session, we do have an evaluation question for you, and I think it's going to get posted in the chat if it's not there already. And that question is, what is most valuable about the TBC at UBC Network sessions? And if folks could take a couple of minutes now or after the session today, just to provide us with some feedback as we look towards next year, to build on what's working and what's engaging and what folks value. Our next network event will be in the fall, and we'll send out an invitation to all network members. If you're not signed up to the network, please do so at health.ubc.ca/TBC, and I think that link just went up in the chat as well. And Christy, do you have anything to add before we wrap up? And just a final thank you to everyone, and I think we can transition to our informal conversation.
Yeah, no, I think this has been a great session, and I'm still overwhelmed by we had a really interesting conversation in our breakout room, and I look forward to our informal discussion to to kind of go into some of the ideas. Just a thank you for everybody who attended and their time and continuing to join us at the TBC at UBC Network. And yeah,